critical care. And they have been missionaries to Zimba Hospital in Zimbabwe or Zambia, sorry, I knew I was going to get that wrong, in Zambia for the last 10 years. And they do really great work over there. Dan's going to tell us about. And I learned a couple things about them that I didn't know. They came and stayed with us last night. And the thing I learned about Joan that I didn't know was the heart that she has for students. Every time we started to talk about all of you guys, she would get teared up. They have a heart for students, and they love you, and they want so much to help you and any of you that feel a call to long-term missions to help show you how to get from point A to point B. It is possible. They've done it. And they have a place to work over there, and maybe some of you will feel called to go and work with them someday. And if you do, you will find out. I found this out about Dan last night as we were watching the Game 7 of the World Series. Go Astros! Right? And Dan is basically a walking sports almanac. I mean, he knows everything. Don't challenge him, believe me, because he knows everything about sports. And so if you go to Zambia and you work with them, you will have to make a lot of sacrifices, but you won't have to give up on your sports news. So you can get it all from Dan if you're over there. So please welcome with me Dan Jones. Don't do this to me. I'll work on it if you want.
Oh, okay. So it looks like we have a good crowd here today. I want to thank you for the opportunity to share with you. One thing I remember from being in medical school 20 years ago, I forgot most of the lectures. One lecture I do remember was a family practice doc from Minnesota. He came and had moved to the inner city of Washington, D.C. to start an AIDS hospice there. And that's where I sort of got the idea that you could pursue a healthcare career where you could go and serve the poorest of the poor in a resource-limited country. So that had a big impact on me. Hopefully you'll be able to pick out one or two things from this lecture and hold on to them as you progress in your training. So I don't have any financial disclosures. I didn't receive any money from a pharmaceutical company to come here and give you this lecture. Then all the patients in the presentation, we're sort of considered that we're friends with each other, and they had no problem for me to show their photos and share their stories with you. They sort of said, no, we want to become famous in America, so tell as much as you want about us. If you've never heard of Zambia, it's on the continent of Africa, and it's most famous for the Victoria Falls. This is why most tourists might come and see this attraction. Supposedly Dr. David Livingstone, the famous missionary explorer from Scotland, was the first European to actually see the falls. So he named it after the Queen of England. The locals, the Zambians in their own language, they call it Mosi au Tunya. This means the smoke that thunders. This is because you can see the mist cloud and you can hear the roar of the falls from a very far distance off, even before you get up to view it. This one's in dry season. In rainy season you couldn't take this same photo because you would just be completely drenched with water from the mist from the falls. A few statistics. Zambia is a resource-limited country. This translates into lower life expectancy because there's less money available for healthcare needs there. There's a severe shortage of doctors in Zambia. There's just only one medical school, and they only graduate 50 doctors per year, and this is supposed to service the whole country. Because this talk focuses on OB or maternal health, a statistic on fertility, Zambia is in the top 10 countries as far as highest fertility rates in the world. This was our arrival date. One question you may be wondering, how did we get there? The other thing that was formative during my medical school was during my 4th year, I did a 1-month international elective rotation at this very same hospital. And that's where I felt God's call in my heart to make a commitment to be a full-time missionary doctor and come back and serve for a longer period of time. And there's a lot of different things you navigate as you progress through your residency training, then getting out, private practice, having large debts, how do you go to the mission field, things like that. But God had His hand on it, and I just had to be obedient and follow that plan. I had a National Health Service Corps scholarship, so the federal government paid for 3 years of medical school, so I owed them 3 years of payback time. I went to Eastern Kentucky and Appalachia and worked there, ended up working there for almost 5 years, but basically at the end of that time period I was debt-free and I could go wherever I wanted to go. That's where I met my wife, Joan. Maybe you've seen her there. She had gone to the medical school in the Philippines, came as a foreign FMG, then had a J1 training visa and switched to an H1 working visa because she went to a doctor shortage area. That's where God brought us together. Joan likes to joke and say that God has a sense of humor because I grew up in a small town in western Pennsylvania on a dairy farm. Joan was from a southern island in the Philippines, Mindanao, and somehow we ended up meeting each other there in eastern Kentucky. Then Joan had left the Philippines because she wanted to come to America and quote unquote have a better life. So I had a big job to convince her, no, you have to give up this better life that you've achieved and come with me to Zambia. And Zambia is much worse as far as development than what the Philippines was. But I thank the Lord that she, after some convincing, she agreed. Shortly after our arrival, it was a wake-up call. Hey, we're not practicing medicine in America anymore. This was one of the startling visual images, a critically ill woman being brought to the hospital in a wheelbarrow by another woman. The hospital is over 50 years old. We serve a large obstetric catchment population. There's 3 health districts. One of them has a hospital but no OR. Then the other health district has no hospital. So we're pretty much it if a woman needs an emergency cesarean section. So we serve a big population, then it covers a wide area as well. This is welcome to my obstetric nightmare. Don't try this at home. This woman had attempted delivery at a rural health center. Her past OB history was significant for having a previous cesarean section. So if you want to attempt to have a normal delivery after that, that's called VBAC, vaginal birth after cesarean section. Now the hospital we practiced at in Kentucky before we went to Zambia, that was a community hospital. And they themselves had outlawed VBAC. They said, no, if you want to do a VBAC, you have to go to a tertiary university hospital where there's 24-hour in-house anesthesia, OB, and a dedicated C-section room. So we're quite surprised that she had a previous cesarean and was attempting a VBAC at a bush clinic or rural health center without any of those things. And to complicate matters, it was a breech presentation. So doing a breech VBAC was even more high risk. Then it ended up with the worst possible scenario, head entrapment. This happened on a Sunday morning at 8 a.m. This rural health center is about 40 miles from the hospital. It takes about 2.5 hours to get there. Then that rural health center does not have ambulance service, so it was the patient's family, their responsibility to organize for a private vehicle to be used as an ambulance to take the patient to the hospital. Because of being on Sunday, those vehicles were very difficult to find. So believe it or not, unfortunately she stayed in this condition for over 12 hours. She never reached our hospital to 8 p.m. at night. So this was sort of a wake-up call, what we're dealing with here. Back in 2011, 70% of the women in our obstetric catchment area preferred this to be their delivery room. This is the bush hut in the village with the grass roof, the mud adobe walls, and the dirt floors. If they deliver at home in the village, they're assisted by a TBA. This is a traditional birth attendant. She's never had any formal midwifery training, but she's delivered a lot of babies at home in the village. These are the 7 items they use for home delivery. There's a plastic sheet. Then out in the village, they're off the electrical grid. If the delivery takes place at night, they have to be able to see what to do. So there's a candle, a box of matches, a pair of gloves for the TBA, a string to tie off the umbilical cord, then a razor blade to cut the umbilical cord. Then the last one's a bar of soap for the mother to bath and then to wash the baby. So these are okay if it's a normal spontaneous vaginal delivery with no complications. But if you have a problem during the labor, you're pretty much stranded because these things here can only take you so far. If the woman fails to deliver at home, again, it's the family's responsibility. They have to get her from home to the closest bush clinic or rural health center. It could be 10 miles away. Typically, they use this for their ambulance transport. It's called a Scotch cart. 2 oxen are pulling the cart, then the labor patient is riding in the back of the cart. To cover that 10-mile distance, it could take a couple of hours. There's 40 rural health centers in our obstetric catchment area that can refer emergency patients to our hospital. Scott told me there'd be some dental students here in the audience, so this is my one dental slide. We do have a dentist at our hospital. He's a dental therapist. He went to India for 6 months for an intensive dental therapy course, but he does the extractions. His other job is that he's our chaplain at the hospital, so he's doing dual jobs. And then so often Joan would go and visit 3 of the rural health centers that are affiliated with our church, and she'd bring along Reverend Shabula as the dental therapist. And out in the bush, if it's hard to see a doctor, it's even harder to find a dentist. So Reverend Shabula was even in more demand than Joan. Joan would often finish first, then she'd go and assist him by cleaning the instruments, helping to speed up the process so they could get everybody seen. But in one day, he could do 40 or 50 extractions, depending on how much lidocaine Joan remembered to bring with her. But Reverend Shabula, not because he was just the chaplain, we also said that he was the most effective evangelist. Because when he was doing his dental therapy and he gave the lignocaine injection, he had a captive audience. The patient was in the chair, they couldn't run away, so he could present the gospel message to them. This was the first rural health center that we visited, Siachitema. This is a typical makeup of staff at a rural health center. The 2 women standing in the background are janitorial. They also do clerical work. They dispense medications. They do vital signs. They also are called on to do clinical duties as well. The nurse kneeling in the front is a regular nurse with no special training in midwifery, but she's conducting deliveries out of necessity. This patient's name was Rosemary Chelo. Then this was our first encounter with how tricky it was for women to deliver at a rural health center or bush clinic, especially if they developed any complications. So this was only 2 months after our arrival. Her obstetric emergency was postpartum hemorrhage or severe bleeding after the delivery, and it was caused by a retained placenta. The placenta did not come out after 30 minutes and she started to hemorrhage. So this is where we found out, oh boy, this is a risky proposition even to deliver at a rural health center. As I mentioned, the nurse was not a midwife. We didn't have any medications available. They were out of stock, no oxytocin, no ketamine. They obviously didn't have an OR to do a DNC. Then they don't do blood banking at the rural health center, so no blood for transfusion, and they didn't have ambulance service. So we had to start an IV and start an IV fluids for Rosemary, load her in the back of our pickup Hilux truck, and rush her to the hospital. She got a blood transfusion and had a DNC and survived. Now, if we hadn't been there that day, then again it would be the family's responsibility to organize for transport to get from the bush clinic to the hospital. These trucks in Zambia are called lorries, and they're usually used like as a taxi, public transport to move people from the village to Zimba town. But they can be booked through the private vehicle system, the owner, to transport an emergency patient. And they often raise the price because it's an emergency, it could be late at night, whatever. So the patient would be on a mattress on the back of its vehicle. So that was one cause for a delay, finding a vehicle to bring the patient to the hospital. This is the second cause for the delay. The road network in Zambia is very bad. There's one main paved road. We call that the tarmac. You branch off of the tarmac and you go out into the bush, in the villages where these rural health centers are, then none of those roads are paved. They're all gravel or dirt roads like what you see here. In rainy season, it's quite challenging. You can get stuck in the mud. There can be huge pools of standing water, and you have to drive the vehicle through there. So the road system is the second cause for delay. So these two causes for delay in access to emergency obstetric care cause big problems. During my time as a medical student, a resident, and in private practice in Kentucky for 5 years, I never saw these two rare obstetric complications, but in Zambia we encounter them on a regular basis. The first one is the ruptured uterus. If a woman has obstructed labor and she stays in labor long enough, eventually the uterus will tear or rupture. These are quite challenging cases. These were two patient stories I wanted to share with you. Ida, on the left, she was a gravid of 5. She delivered normally at home with the 4 previous pregnancies. She thought, okay, no problem. 5th pregnancy, I should be able to deliver at home again, but she had obstructed labor, was in labor for over 24 hours, and she ruptured her uterus. She survived. This photo was from a home visit I did on her 3 months post-operatively. She had just started to resume some of her normal activities with farming. On the right there is Onis. She had, it was her 3rd pregnancy. She had a history of previous stillbirth, but the first 2 deliveries were normal vaginal deliveries. She was attempting to deliver at a rural health center, had obstructed labor, was referred to our hospital, and was diagnosed with a ruptured uterus. She stayed an extra couple of weeks because she even had damage to her ureter, which can happen because of the distorted anatomy. But the take-home point in the red letters there, no previous history of cesarean section, so no scar on the uterus, but they still managed to rupture the uterus. We had a visiting surgeon from Lynchburg, Virginia. He came for 1 month in May 2013. He had volunteered at some other mission hospitals in Africa. And he said the one case that he dreaded receiving was a ruptured uterus because he had never taken care of that one before. So I think he jinxed himself during the 1 month he was there. He had 3 ruptured uterus cases, so he became very proficient and an expert at doing a hysterectomy after ruptured uterus, but all 3 patients survived. So the incidence here in the U.S. is quite rare, less than 1%, and this is women who are attempting VBAC. However, in the developing world, it's occurring 10 times more frequently, and 3/4 of the cases are women with no scar on the uterus. 1 in 17,000, that would be the chance of a woman to rupture her uterus here in the U.S. with no history of previous cesarean section. In West Africa, all comers, this one was in Nigeria. It can happen as no scar or scar. It can happen as frequently as 1 out of 120 deliveries. The second complication was obstetric fistula. This one is a big problem, also medically, but also psychosocial as well. These women are incontinent of urine after their delivery due to the fistula. Then they can be ostracized in their own villages. There's a stigma attached to it because of the foul odor, so no one wants to interact with them. So they get very little social programs because they're separated or isolated in their village. So there's a big component of depression, psychological problems, in addition to the medical problems of being chronically incontinent of urine, chronic fatigue, insomnia. The first patient, Belita, was quite shocked when she said that she had urinary incontinence for 24 years. She had a complicated delivery in 1979 and had leaked urine on herself since then. She had no idea that there was an operation available to repair the problem. There's only one fistula repair surgeon in the whole country of Zambia. His name's Michael Breen. He's a gynecologist from Ireland. He's been in Zambia 15 years, and he estimates he's done over 1,000 of these fistula repair surgeries. The middle one, Agnetha, she's from the farthest rural health center. It's 100 miles, and it takes 4 hours to get there. She was one of the 3 patients that the surgeon from Lynchburg, Virginia took care of. She had a ruptured uterus and developed the fistula problem after that. The last patient, Loveness, she has what we call bad obstetric history. She's been pregnant 4 times in her life, but she doesn't have any living children. She'd had 3 previous vaginal deliveries. 2 were stillborn. 1 was born alive, survived to 1 year old, then died. Then with her 4th pregnancy, she attempted home delivery, even though she had diagnosis of bad obstetric history. She had obstructed labor, was referred to the hospital. Luckily, she didn't rupture the uterus, but she still needed a cesarean section because the stillborn baby couldn't come out, and she developed fistula after that. I had the privilege of following her up on a home visit a year after her surgery. We left Zimba at 8 a.m. and we never reached her village till 12 noon. It was about 75 miles due to the poor road conditions. But she was happy to report that the surgery was 100% successful. A year out, she was completely dry and she'd been reintegrated back into the community. So it's a big problem, fistula in Africa and then other parts of the developing world. It's due to what's called CPD, cephalopelvic disproportion. This is where the baby's head is too big, the mother's pelvis is too small. So during the labor, the baby's head can descend only so far into the pelvis. Then when arrest of descent happens and the head is deep in the pelvis, it puts pressure on the maternal tissues. Then that causes ischemia, that causes necrosis, then a tract or a tunnel forms between the bladder and the vagina. And that tract, another terminology for it is VVF, vesicovaginal fistula. This is what causes the chronic urinary incontinence. She was our nurse, Luncheon. We came back to the States after our first term finished in July 2011, and we're here in America for 1 year to do fundraising, check with our visiting church, with our churches, our church visitation schedule, the churches that have been sponsoring us. So we were only here about 4 months, then we received a devastating text message from Zambia. Lanti had been pregnant when we left. When she went to deliver, she had CPD, had a cesarean section. Then after the cesarean section, she developed postpartum hemorrhage, and she bled out in the postnatal ward and died. So this was devastating news. Very sad that one of our own staff members, this was like the best that we could offer her. So while we were home that year in the States, we did special fundraising to do a maternal health improvement project. We wanted to improve the facilities and services for pregnant women that we're offering at our hospital. Here in the U.S., there's more births, but there's less maternal deaths. In Zambia, we have fewer births, but we have more maternal deaths. So this translates into a much higher maternal mortality ratio. These are the causes for maternal mortality. The number one cause is postpartum hemorrhage, followed by those other 3 obstetric causes. Then we do have a high HIV incidence in Zambia. About 15% of adults are HIV positive. So we have a lot of pregnant women who are positive. Then depending if they're started on antiretroviral treatment or not, sometimes their HIV condition can get much worse during the pregnancy if they're late to present and or late to start on treatment. So indirect causes cause about 1/4 of maternal deaths. So the number one cause for postpartum hemorrhage is called uterine atony. This is after the delivery where the uterus is flabby and it's relaxed and it doesn't contract well. Then the woman has severe bleeding, and this is what's going to cause most of the maternal deaths in the developing world. The risk factor for uterine atony is a high number of pregnancies. So believe it or not, I've actually encountered 2 patients in Zambia that were gravid at 13. They've been pregnant 13 times in their life. One was pregnant at 29 weeks and developed severe preeclampsia. We had to induce her. The other one was at term, and she presented with antepartum hemorrhage or bleeding before the labor started. And this was due to placenta previa, so we had to do an emergency cesarean section for her. In our maternity ward, we have 2 medications available to treat postpartum hemorrhage. The first one is the injection, oxytocin. The second one is the tablet, misoprostol. If these fail, then we can resort to this device. It's called our uterine balloon tamponade. It's been studied in resource-limited settings, where you insert the balloon into the uterus, then you instill 500 mLs of normal saline. Then that causes a compressive effect on the vessels on the uterine wall and can arrest the hemorrhage. If this fails, then the last resort is hysterectomy. This is our high-risk OB setup prior to our maternal health improvement project. Believe it or not, in our maternity ward, we only had 1 delivery bed. This was very challenging. If 2 women came in labor at the same time, do I pick her, or do I pick her to go to the 1 delivery bed? So it was like a race or a competition to see who could deliver the fastest to get to our 1 delivery bed. We do have a mother shelter on the back half of the hospital compound. This is where women who stay in a faraway village come and they camp out during their last month of the pregnancy at the mother shelter to be close to the hospital. But they have to fetch their own water, they have to prepare their own food, and some of the shelters you can see there are not enclosed, so they're exposed to the elements. This is a problem during rainy season and during cold season. Margaret in the center photo there, she had a precipitous delivery at the mother shelter in that bottom right one. That's an outdoor toilet. And luckily the baby did not fall down into the pit latrine there. The security guard was called, brought her to the maternity ward. The midwife was getting ready to deliver the placenta. Then she got very surprised because she found another baby inside the uterus, and it was undiagnosed twins. Margaret had no idea she had twins. We had no idea, but she was staying at our mother shelter for 3 weeks. So we said, this is not the best setup for these high-risk conditions. So after our 1-year maternal health improvement rehabilitation project, we increased from 1 delivery bed to 5. Our postnatal, we increased from 6 to 11. We have 2 NICU rooms with 4 incubator beds. And the biggest improvement was our new antenatal ward. We went from 0 to 17 beds. Women with high-risk conditions, twins, placenta previa, previous cesarean section. They're disqualified from staying at the mother shelter. We admit them to the antenatal ward for the last 2 or 3 weeks of their pregnancy. This is so we can make a safe birth plan, and this has helped us to improve our high-risk outcomes for mothers and babies. These were a few difficult OB patients that had special conditions. The top left, Dorcas, she was diagnosed with squamous cell carcinoma of her left eye, and the visiting eye surgeons from America were getting ready to do her operation. Then she said, "I feel like I have to push." And she never told them that she was 29 weeks pregnant. They rushed her to the labor ward. She delivered a 1.1 kg baby. They stayed in the NICU for 6 weeks. Then she was discharged and came back 4 months later. The visiting eye surgeon from Wichita, he did an extensive 4-hour enucleation procedure to remove the cancer. The top right was Machina. She has congenital dwarfism. She was referred as an emergency patient with CPD. We did a cesarean section. Otrina on the bottom right, she was one of the first patients to stay in the new antenatal ward. She was born with a congenital legs deformity. She was unable to walk. She was using a wheelchair. We did an elective cesarean section for her. Pamela on the bottom left, she had 2 previous cesarean sections. She was admitted to our antenatal ward. She went walking one night, she fell into a ditch, and she sustained a tib-fib fracture. We splinted her, did her 3rd repeat cesarean section and a tubal ligation. She stayed in the postnatal ward for 1 week, and she rode the bus for 6 hours to the capital city of Lusaka to a cure hospital. The orthopedic surgeon did an open reduction internal fixation to repair the fracture. My most favorite patient is Lista there in the middle. Her home village is about 10 miles from the hospital. She presented at 27 weeks. Her special condition was epilepsy. She had a seizure disorder. In Zambia, they do outdoor cooking over an open fire, and it was bad timing that she had a seizure when she was cooking. She fell down into the fire. She had a circumferential full-thickness burn of her left lower leg from her knee all the way down to her toes. She was in critical condition when we admitted her to the antenatal ward. A couple of times it was touch and go. I didn't think that she would survive. We had to give her IV fluid rehydration, antibiotics. We started her on the seizure medications again. We had to do the fetus monitoring, NST ultrasounds, and very meticulous wound care to try to limit the infection. After about a month, she pulled through and was stable. Now the next problem was that she needed a skin graft, and I'm not a plastic surgeon, I don't know how to do a skin graft. Then in the last 5 years, we only ever had one volunteer plastic surgeon come to our hospital. He was Dr. Joe Woods from Atlanta, Georgia. And it was sort of God's providential timing that he brought Dr. Joe right when we needed him to do the skin graft surgery for Lista. He took the donor skin from the thighs and reapplied it to her left lower leg. And we had about another month of meticulous wound care because we didn't want the skin graft to reject. When she was 36 weeks pregnant, she began to mobilize. She thought about going back to the village to deliver, but we convinced her, no, just stay here. We've done a lot of work here. We want to have a good outcome for the baby as well. She had a normal vaginal delivery at 39 weeks. Then she gave me the special honor of naming the baby after me. She said, "Dr. Dan, you've done a hard job to save my life and the life of the baby." So for the past 3 years, she's been coming back to get refills of her seizure medications at the outpatient clinic. Then I'm happy to report that baby Dan is a healthy 3-year-old boy now. This is our C-section room in the OR at Zambia Mission Hospital. 2 things to take note of here. If you look at the clock on the wall there, it's 2:30, but it's not 2:30 in the afternoon, it's 2:30 in the morning. So if you're thinking about OB, you have to get used to the idea of sleep deprivation because emergencies do happen in the middle of the night quite frequently. If you look at the other thing, there's a pink curtain, then that's the window to the outside, and you see it's dark. During the first 5 years, this was a challenge because of the unstable national electrical grid. We had also no backup power supply at the hospital. So in the middle of the C-section, the lights could go out and everything was pitch black in the OR. The nurse would bring like a little headlamp, then you'd have a circle of light, then you finish the operation as quickly as possible. But this was not good for patient safety. We were very fortunate, the Franklin Graham Samaritan's Purse organization, they donated a Cummins diesel generator. It came in October 2012, and some missionary electricians from Pennsylvania came and installed it. So the last 5 years has been like a cool breeze because it's been much easier. It's like night and day. Now when the power goes out and you're doing the surgery, you have no idea that the power went out because it just switches to the generator automatically. So the WHO recommends a national cesarean section rate between 10 and 15%. Here in the US it's too high, in Zambia it's too low. If I had to pick between the two, I'd pick the one that's too high. If you pick the one that's too low, then you see all of these problems: maternal deaths, obstetric fistula, and ruptured uterus. So we were shooting for that 10% goal, and we got very close to that the last 2 years in 2014 and 2015 for our maternity ward. So in addition to maternal outcomes, you can also improve neonatal outcomes as well. I had a mystery case to finish up with here. This is my other favorite patient, Mizinga Mubiana. It was her second pregnancy, and she was 36 weeks pregnant. She presented to our antenatal ward. Her chief complaint was, "I've not been able to walk for 1 month." I don't know if anyone wanted to take a stab at it. What could cause paralysis in a pregnant woman? Yes, yes, that's a very good thought. What would cause pressure on the spinal cord, or what would you want to do to work that up? So here in the U.S. we do MRI of the lumbar spine. Now, would you think, do we have MRI in Zambia? Probably not, but believe it or not, we do. There's a private hospital in the capital city, Lusaka, called Fairview Hospital, and if you pay $300, you can get your MRI. So her and her husband are both school teachers, so they have some disposable income from their salaries, so they were able to do that. She stayed in her antenatal ward for 1 month, then not able to walk the whole time, in the wheelchair. She did deliver vaginally, believe it or not. She had some control of her pelvic muscles, and she was able to push. This is the 2-year-old boy now, and this photo was taken from 2 months ago. You can see there she doesn't look paralyzed anymore. So after she delivered and they organized for the funds to go to Lusaka, they did the MRI, then the diagnosis came back as a Pott's disease. She had tuberculosis of the spine. And this is not an uncommon thing. I guess it can happen in Africa. Pregnant woman getting paralyzed because in the 9th month of pregnancy, because of the abdomen distending, changing the curvature of her lower spine, the lumbar spinal nerves get more pressure put on them due to the deformity from the TB. But she took TB drugs for 1 year, then did physical therapy and rehab, and now she can walk around perfectly normal, and you would have never known that she was paralyzed. And she went back to work as an elementary school teacher earlier this year. My last person I wanted to mention was one of my friends, Malindi Simongo. She gave permission to use her story, but we first met her in July 2010. She was admitted to the female ward on death's door. She had advanced HIV disease. Her CD4 count was less than 50. It did not look like she was going to survive. Dr. Joan took care of her daily in the female ward for 5 weeks. She got started on TB drugs and ARVs. After 5 weeks, she had stabilized and was able to be discharged home. Then for the past 6-7 years now, she's been coming every 3 months to get refills of her medications at our HIV clinic at the hospital. For the first couple of years, she was still not able to walk. She was complaining of neuropathy or pain in her legs and hips. We adjusted her medication slowly with some rehab and physical therapy. She started to be able to walk. Then we do receive medical students and residents who come for elective rotations. Most of the patients don't speak English. They speak the local language, Chitonga. So there's a need for interpreters. And so Malindi was hired as an interpreter 2 years ago. Then she breaks down the communication barrier by translating back and forth between English and Chitonga. So now she looks perfectly fit. She gained 40 pounds back that she had lost due to the advanced HIV. Then she's able to walk 1.5 miles from the home village in the morning to the hospital for work, walk 1.5 miles back home at the end of the day when she knocks off. But Malindi had a good testimony. She was very appreciative of the assistance that we gave her and being able to make her diagnosis and start her on treatment, and she was able to recover. And she said, no, often when I'm interpreting, the patients will make comments that they see Christ working through Joan and I in the way that we serve the patients. So that was a very humbling appreciation to receive from Lindy, then part of her motivation for becoming an interpreter, she said, no, I've been assisted, so I want to be able to assist patients and volunteers when they come so they can have a better experience. And I think that was the last slide, but I'll stick around afterwards if there's any individual questions. Thanks so much.
Thank you. Just imagine how many people are alive in Zambia because of the work that they've done for the last 10 years. So we bring speakers like Dr. Dan and Dr. Joan to come and meet you guys, talk to you guys, because we want you to be able to see that it is possible for God to take a doctor from Pennsylvania and a doctor from the Philippines, put them together, and send them off to Zambia and place where that they can serve and that they can save many, many lives and that they can share the gospel of Christ. So if you guys have any kind of call on your life, any kind of interest in this area, these are the people that can really show you how to get from here to there. And it's not easy. We know. We see a lot of people every year, a lot of students every year that feel like God might have a call on your life, but you don't have any idea how to get from here to there. These are the people that can help show you how to do that. So I know that some of you have to leave, but if you have a few minutes to stay around, we have a few minutes before I have to take them to the airport. So come and talk with Dr. Dan and Dr. Joan about it. And glad you guys came today. Next week we'll be back in the same room, and next week will be our last one of the semester.